So I'm now going to hand over to Graham Martin, and he's the Director of Research at the This Institute Trust. And this is going to be a really interesting talk. It's all about how do you communicate effectively what evidence means to the healthcare decision makers. And I think we've all learned from the COVID inquiry recently that explaining simple topics like relative and absolute risk can actually be quite challenging, and people don't understand what you're saying. So over to you, Graham.
Good morning, everyone. So the concept of evidence-based medicine is now pretty well established. It's got its limitations, it's had its critics, but it's fairly unthinkable now that for something like a new health technology or a new drug, it would go any other way. So you would establish a really good evidence base, you would make sure it's effective, it's cost effective, and perhaps most importantly of all, you have a clear means of translating that into routine healthcare practice, for example, through National Institute for Health and Care Excellence health technology assessments. Things are a little bit different in the field of health services research on organisation, delivery, and so on. We don't have quite such a well-established mechanism for translating research into practice, and accordingly, practice is that bit more variable across the healthcare system. Now, of course, there are good reasons for that as well. Health services research is not the same as clinical research. It's very rare to find a piece of health services research that is universal, that applies equally everywhere, that doesn't require the intuition, the knowledge, the judgment of practitioners to translate it effectively, to adapt it to their contexts and so on. So in some ways, this isn't worrying, but in other ways, we want health services research to impact healthcare delivery. That's why we're health services researchers. We want what we do to have relevance, to have resonance, to have impact in the healthcare system. So what are the implications for us as health services researchers, for decision makers, practitioners, and others in the healthcare system around how best to translate, mobilize health services research knowledge in practice? Well, that's what this session is all about, and with a particular emphasis on the way in which senior decision makers, boards, policymakers, others in the NHS make use of health services research evidence. So we've got three presentations. We'll be starting with Gillian Russell, who is Director of Health Workforce in the Scottish Government. That will be followed by a presentation from Jean-Frederic Levesque, who is at the Agency for Clinical Innovation in New South Wales and Australia, who'll be talking about that body's work in translating evidence into practice during the COVID-19 pandemic in particular. First of all, though, we have a presentation from Sonja Marjanovic, who is at RAND Europe, and she'll be talking to us about some very interesting research that RAND did with the Health Services Management Centre at the University of Birmingham, looking at how NHS boards make use of evidence.
Board members within health and social care organizations play a key role in organizational governance and in shaping strategy, culture, and organizational performance. They're expected to make decisions on a wide range of topics that can affect the quality of care their organizations provide. And given these roles, it's important that the decisions board members make are informed by the best available evidence. Now, while there is some research into how boards use knowledge and organizational intelligence more generally, so for example, insights from service evaluations and organizational performance data, we know comparatively less about how boards use evidence from research specifically to inform their decision-making. It's in this context that this institute commissioned researchers at RAND Europe, which is where I work, and colleagues at the Health Services Management Centre at the University of Birmingham to conduct a scoping study to begin to better understand how boards use evidence from generalizable empirical research specifically, and any scope for improvements in this regard. As this was an exploratory scoping study, we based our approach on a brief and targeted review of the literature, but focused mainly on gathering primary data through 17 in-depth, semi-structured interviews with board members of 7 health and care organizations in England, and these spanned NHS Trust and integrated care system boards. We found that all of the boards we spoke to engaged with research evidence to some extent, And the types of research they used spanned evidence from clinical research, health services, and organizational science and management studies disciplines. But the use of research evidence at board level was by and large relatively sporadic and opportunistic, rather than systematically and routinely embedded into board functions. And this was influenced by a range of issues related to the nature of the research itself, to the board structure, culture, and function, as well as wider external environment circumstances. But we also explored possible ways in which boards could be supported to make better use of research evidence in the future. And some of the actions we identified have implications for the research community and others for boards themselves. And I guess before I move on, I just wanted to flag that the work we did was exploratory. It was a scoping study, and so it was of limited scale. And as such, we couldn't assess the feasibility or the effectiveness of the actions that were suggested. However, the insights we gained, I think, do really lay a foundation for future studies in this important area, and they begin to shed light on what senior decision makers at board level think could add value. So, one key area for improvement has to do with the nature of the research evidence that is produced and the need to make it more usable for health and care board members. So in addition to the need for research that is timely and relevant, a key message here had to do with the importance of making sense of research findings in a way that is meaningful to board members and in a way that they can relate to. So some suggested ways of doing this include efforts by researchers to make explicit statements about why research findings matter for board level decision makers, and perhaps to pull out short lists of actionable recommendations in the research outputs. Efforts to flag potential limitations in the data and possible real-world limitations to actually acting on research findings were also something that we identified as important. Improving researcher skills in communicating research to non-academic audiences was also flagged to matter, and some board members suggested using individuals or knowledge broker organizations as intermediaries to help translate research findings into more bespoke messaging for board members. Closely related to this, there's also scope for improving how research evidence is communicated in terms of format and style. So there was significant appetite amongst many of the board members we spoke to for simpler and more accessible formats than journal articles present. So some examples of this include presentations or workshops for board members, research summaries, blogs, infographics, and case studies, really anything that can tell a compelling story and a relatable story. And disseminating research findings in media outlets that board members consult was also seen as potentially having an impact. So, for example, both general and health or care specific news services. We also identified a need to improve board member confidence and skills in interpreting and in discussing, and really importantly, in critiquing research findings to help ensure that they use research evidence effectively. So board seminars, development-focused sessions were suggested as potentially helpful in this regard, as was training board members on asking the right questions and on assessing the quality of research. This was really in the context of mitigating the risks of research evidence being used too selectively. And then finally, our scoping research also identified a need to create a conducive board environment and conducive processes to support the use of research evidence. For example, through having designated board member roles for research or working groups or subcommittees charged with engaging with research. And another suggestion was to include a slot that focuses on research evidence in board meetings as a standing agenda. So I hope that this snapshot of the findings from our scoping work was of interest, that it helps illustrate the really socio-technical nature of this topic area. And I hope it's helpful for informing a future research agenda, as well as practical efforts to help ensure that health and care boards make decisions that affect us all based on the best possible evidence, including that from research.
Hi, everyone. My name is Jean-Frederic Levesque. It's a real pleasure for me to join you today to talk about communicating evidence to healthcare decision makers and share especially some learnings that we did during the pandemic and share some examples about the work that we did in New South Wales, Australia. First, I want to reflect on the fact that one of the key driver of evidence to support innovation and policy has been the realization that there's different forms of evidence that we need to mobilize as part of the work we do, and decision makers are really expecting those different types of evidence to be triangulated together. There's research evidence coming from the peer-reviewed and grey literature. There's empirical evidence which relates to quantitative data assessment. And of course, there's also experiential evidence coming from clinicians, consumers, managers that we collect through qualitative data that is also very important. And one of the things that really has been successful for us has been the realization that none of those three sources of evidence can entirely fulfill the need for information and evidence to support decision-making in healthcare system. You really need to combine them together, harnessing innovative ways such as rapid synthesis and living evidence, clinical variation assessment and predictive modeling, as well as crowdsourcing and deliberative processes to really convince decision makers that what they've got in front of them is a full suite of evidence. So I want to share some insights coming from the work we did during COVID-19, and especially share the work of the critical intelligence unit that we created at that time. And I invite you to go to our website where you will see all of the products that we've created during the pandemic, the different ways we've tried to convince decision makers to change some of their policies and adopt at times also different ways to progress policies. So the COVID-19 Critical Intelligence Unit was established in March 2020, and it was to be at arm's length from operational centers, really making sure that we had people looking at all of the evidence emerging around the pandemic without having to, on a day-to-day basis, constantly be drawn towards more pressing issues. The Critical Intelligence Unit was a unit that had time to look at things and dedicated space to look at things and then provide advice back to the Secretary of the New South Wales Health System and other decision makers. And it provided intelligence and advice based on rapid reviews of the literature, had for mandate to generate regular integrated data reporting. We were in charge of gathering international and local experiences and also catalyze health systems research to support the pandemic response, as well as coordinating modeling approaches. And I want to share straight away some key characteristics of its business model that really made that model a successful one. First, it was providing challenging advice, but in a safe space, so that the evidence, even though at times it was challenging compared to what was originally planned, could actually be discussed in a robust way. It also acted as an integrator of work happening across different branches and different organizations, and therefore was a disruptor of each of those branches and organizations' previous ways to work and previous ways to think. It integrated evidence, data, and clinical expertise, and that was really one of the key success factors. And finally, it was non-decisional. And even though at times we disagreed with some of the decisions that were made, we understood that there was more than evidence that had to be considered for some of those very critical decisions to be made. There are three things that we did that we felt were innovative to leverage evidence for the purpose of policymaking. And the first one was a ruthless approach to timeliness. We always needed to provide the work and the advice we were providing at the time that it was needed for policy decisions and decision makers' time frames. And that meant we had to go always towards the good enough instead of the entire comprehensive kind of approaches. We needed to triangulate the different sources of evidence, as I've already mentioned, and we needed to be very innovative in the way we would model things, linking data in a different way to be able to model things that we had never been able to model before. So just to provide a few examples of the work that we did, of course, some of our core outputs were around the evidence syntheses that we did. We had a daily evidence digest scanning the literature, providing to thousands of people in the state a daily dose of COVID-19 and the evidence that was emerging across the world. We were doing evidence checks, which were really rapid syntheses, very often provided on a 24, 48, or 7-day, 24, 48 hours or 7-day perspective, so that, again, they would be very highly timely. And also we used a lot of living evidence tables that were always available, always up to date, so that decision makers can, for some key topics, always go back to our website and be able to have the full suite of knowledge up to date at that time. And the example that we've got there, of course, is around vaccines, which was a highly evolving topic at the midway through the pandemic. We also produced syntheses that were reflecting on the evolution of the evidence throughout the pandemic. And that's important because sometimes what was evident in March was not evident anymore in June, or at least the evidence had evolved, and the things we thought were true in March were very different now in June or July. And reflecting on this, such as in this specific example about mask wearing, for example, was really important so that decision makers could also be informed about what are the things that the media or different groups are still coming back with, but have been disproved by now, and how has the evidence moved on to a great extent. And that was really powerful because it was helping decision makers to reconcile that what we knew about long COVID a few years ago, for example, was not true anymore 2 years later, because of different level of immunization, because of different level of natural immunity in the population. And understanding that helped them to reconcile things that at times can look very contradictory in nature. We also produced experiential evidence using crowdsourcing and social media, really engaging clinicians and citizens in generating evidence about what they felt was the current knowledge from their perspective, from their experiential, knowledge base from within the system, and really provided a rigorous approach to generate this so that decision makers would see it at the same level as the other sources of evidence. We produced many dashboards triangulating different data sources. So for months and months, we produced a daily incident controller report, aggregating different pieces of information coming from different branches in the ministry together, a local health district weekly report, as well as a risk monitoring dashboard that was enabling us to position the risk rating in different hospitals and ensure that we could align the policy according to very strong and rigorous data and dashboards. And we use predictive modeling, but again, mobilizing it in a way that would help to reconcile different kind of use of these kinds of complex modeling. So we use geography and mobility to inform decision maker about where was the next hotspot in New South Wales in terms of COVID. We use public health-based modeling to look at the impact that vaccination would have on transmission and how many COVID-19 cases would we predict. We use systems operation data and modeling for the purpose of informing the likely trajectories of COVID-19 patients, and finally, look at modeling that was looking at how to manage organizational constraints in terms of resources by pooling together data that related to hospitals and local districts operation, bringing them back together as a compendium of models, again, so that decision makers could actually see that there was not only one model able to answer everything. Real insight and intelligence was coming from pooling those different models together for different purpose. And one of the things that we always worked on was also to link back all of this to practice and policy. First, through clear engagement structures, such as a health system advisory council bringing together key clinicians across the state to reflect on things, but also a variety of communities of practice that were the users of the evidence that we were producing and the ones translating them into new models of care. We linked back into policy and practice also by positioning the evidence we were generating across a pipeline of change, making sure that we would go from refined stages where we use continuous improvement methods towards more pilot, spreading, and scale approaches by putting evidence at each of those stages. And finally, we brought intelligence and sense making into the mix by really highlighting best bets. What were the information coming out of the living evidence that were giving the best insights possible to decision makers, and also clearly identifying from the evidence what were game changers, studies and syntheses that were changing the way we would see things, and therefore really bringing to the front the implications for the system. So just to conclude, I just want to share some insights about our experience. And the first insight is that we really committed to evidence as a unit, but we had no attachment to decisions. Decisions were the decisions of decision makers, and we were there to provide, in a fearless way, the evidence required to inform and influence. We could disrupt thinking within a safe space, and respecting that safe space was very, very important. We could reduce uncertainty and really focus on where complex issues needed to be simplified for the purpose of decision making. We had to be succinct, timely, and good enough, as I've said before, and really have a really tight scoping around the information need and the issues that were raised, and stick to that so that we would really truly answer the questions. And finally, investing in building trust was absolutely fundamental. Without that trust, the evidence ultimately would not be used. So I want to thank you for giving me the time today to share some of our insights. If you want to learn more about the Critical Intelligence Unit, it has been published in the peer-reviewed literature, so you can read about our experience, and I look forward to the discussion during the conference. Thank you very much.
Hello everyone, and thank you to this Institute for the opportunity to speak to you today. My name is Gillian Russell and I am the Director of Health Workforce in the Scottish Government in Edinburgh. I know that the session today is looking at the role research should play in policy and delivery of health services. As a national policy maker on the panel, I thought it would be helpful for me to look at high level on the following issues. The first is the overall strategic context in Scotland within which the health workforce is delivered. The second is to reflect on the overall approach to research and evidence and policy development and how it shapes that operational delivery planning. And finally, to give you some examples of what that looks like in practice. So to start with the overall strategic context, our focus in the Health Workforce Directorate in Scottish Government is to make the best possible health and care outcomes for people by providing leadership support, policies and initiatives in the NHS in Scotland. Our overall vision for the NHS in Scotland are that people are able to live more years in good health and that we reduce inequalities in healthy life expectancy. Our workforce is central to implementing that vision and delivering a whole system approach to improving health and wellbeing outcomes at every stage of the journey. This is really important around the skills in particular that our health and social care workforce has. As part of that overall picture, we have a workforce strategy for Scotland. It's a 10-year strategy that was endorsed by the World Health Organization. Within that strategy, our vision is a sustainable skilled workforce with attractive career choices and fair work where all are respected and valued for the work that they do. Within that strategy, we have set out 5 pillars of the workforce journey. That is plan, attract, train, employ and nurture. And all of our strategic priorities sit under those pillars. That vision and those pillars are underpinned by the following values. Those values are continual improvement, engagement, honesty, co-design and accountability. Working with partners, we are committed to create the conditions to successfully recover from the pandemic, to ensure that we have sustainable services for the future and transforming the workforce to ensure improved population health outcomes here in Scotland. NHS Scotland employs around 180,000 staff, which is around 3% of the Scottish population, and it makes us the biggest employer in Scotland. In addition, there are 160,000 staff employed in our adult social care sector. The cost of the health workforce alone is £10 billion, which is 25% of the Scottish budget here. My national responsibility combines traditional policy making, using evidence and research, with the delivery of a sustainable workforce, putting in place and implementing operationally focused interventions around education, training, recruitment, pay, leadership and well-being. The current challenges that are facing our workforce services are significant, and we are facing increasingly difficult decisions around funding. Within this context, it is imperative that decisions we make and advice we provide to ministers is based on credible and relevant evidence. It's become increasingly important to understand the workforce here within the global context, because in Scotland we need to attract and retain the best of the workforce. And understanding the global labour market is also critical. Looking forward, we are planning a series of assumptions looking at future size, shape and skills mix of our workforce that will help us understand demographic and other burdens. The importance of getting the balance right between workforce, infrastructure, technology, innovation, and how that links to productivity is critical to us. So I've spoken a bit about the workforce strategic context, now some focus on evidence. I would particularly focus on the Scottish context, where we have a Scottish approach to service design, where people are supported and empowered and actively participate in the definition, design and delivery of public services, from both policy making to service improvement. It supports collaboration, shared ambition, and enables and empowers inclusive approaches. Within the Health Workforce Directorate, we embrace that Scottish approach through meaningful dialogue with stakeholders at all levels. Another important aspect of our work here is partnership working. We work in partnership and co-design with health and social care workforce partners, including our staff side trade unions and our employers, and we have 20 years of practice at this. Partnership working very much supports evidence-based policy development, triangulating different elements of the system together so that we are making sure that we are designing our policy in a way that's going to best deliver. Within Health Workforce Directorate, we also have embedded clinical advisors who will advise on all aspects of the work that we do, for example, looking at the skills that we need in our medical workforce for the future. We also have an embedded chief people officer who works on best practice around our HR practices, including development and delivery of HR policies across our system. I also work very closely with our chief nurse, who has responsibility particularly for the nursing, midwifery and allied health professionals within our system. Overall, we blend evidence with anecdotal information from the front line, along with peer evaluated and reviewed evidence. So some practical examples to bring this to life. The first one I wanted to talk about was the Nursing and Midwifery Task Force. This task force came about as a result of our Agenda for Change negotiations in the last financial year. Broadly, it follows the World Health Organization's State of World Nursing Policy framework, and so it's been really, really important for us that we've had the World Health Organization facilitating and supporting that work. In particular, it's about ensuring that we are recovering and having the transformation within nursing and midwifery that we need for a sustainable future. Membership comes from staff partners, from NHS employers, from academia across nursing and midwifery. It's about valuing the contribution of our nursing and midwifery professions and listening to their views about how we can create sustainability for the future across the 4 pillars of practice: clinical practice, education, research and leadership. The task force will be recommending actions which we in government will put into practice across culture, recruitment, retention, diversification and leadership. These actions will be supported by evidence and the views from the current and future nursing and midwifery workforce. In particular, we have engaged in a listening exercise with the nursing profession so we can really hear the views of the front line and help those views inform our thinking. There are a few further examples of our approach that I thought would be helpful. The first is around the work we are doing on our improving wellbeing and workforce culture strategy. We will be putting in place a new plan and framework to drive wellbeing and workforce cultures across the system. It's been important that we've done that by listening to and understanding the diverse needs of our workforce and reflecting on what really works well to drive the improvement that we're looking for, looking at different delivery models across that system. An example from leadership would be the work that we've been doing to embed compassionate and collaborative leadership across our system. This is through our national training programme Leading to Change. This programme has been very much about designing leadership at all levels across both health and social care system and focusing on our social work profession as well. One aspect of that has been our Aspiring Leadership programme, working with psychologists and others. We've been working on the sorts of conditions and behaviours we want to see in our leadership cadres and how we work with those cadres around professional training and development to make sure that our talent pipeline is meeting those conditions. A final example would be on equalities, where we've been addressing issues around race across our workforce, working with the Commission on Racial Equality to develop training that's going to be based on survey work we're doing with our workforce to understand what matters most to them. So in conclusion, I hope that the examples that I've given today, along with the strategic context I've set out and the way in which we approach the use of evidence and research will help inform the discussion to come. And I very much look forward to the questions as part of that panel session. Thank you.
Well, thank you very much to our presenters for 3 really stimulating talks there. And very good to see in particular from Gillian's presentation at the end there, connections across to some of the themes that Kevin Fong was speaking about earlier on. It's almost as if we planned it. Now, unfortunately, Sonja can't make it due to a prior engagement and Gillian is unwell. So we're without those 2 panel members. We're also, unfortunately, having technical difficulties in connecting with Jean-Frederic. So it looks like it's going to be a 3-person panel, but the quality of at least 2 of those people more than makes up for the slight deficiencies in quantity. So I'm very pleased to welcome Asutosh Yagnik, who has a very interesting portfolio of roles. So he has worked in drug development research. He has worked in organizational development as a management consultant, and he's also a non-executive director at the Clatterbridge Cancer Centre. So I think those 3 perspectives combined give him a unique view on these kinds of issues. Also really pleased to welcome Stella O'Brien, who is a researcher, a citizen scientist, an activist, and she's also chair of this institute's Involvement and Engagement Advisory Committee. So thank you both for coming along, and I'm really looking forward to discussing some of these issues with you. Asutosh, I'd like to turn to you first and actually put to you the premise of this session and some of the things that I said in my introductory spiel, where I was drawing something of a contrast between the nature of research evidence relating to clinical innovations, drugs, health technologies and so on, and the way that those get into practice, and the nature of the evidence space and therefore the routes into practice of more organizational research ideas. And I suppose I ask you quite frankly, do you agree with that characterization first of all? Do you think it's a fair one? And I think you're very well placed to comment on that, given that you've got a foot in all 3 camps.
Thank you, Graham, for the wonderful introduction and also for the invitation to attend this amazing series of talks and conference. It's a real pleasure to be here and an honor. So I think it's a really interesting question. there is a vast difference between what one does in clinical research or preclinical research and actually translating that into real world. So yes, I would agree, in short, with what you're saying. And there's a number of challenges, I think, with that. And the challenges focus, I guess, on issues such as time lag, the research complexity, differing priorities and agendas. Policymakers have to consider a number of multitude of competing priorities, and communication itself and dissemination of that information. And we've seen from the talks that were given earlier about, when you look at the evidence that comes out from COVID, well, actually, how do you disseminate and communicate that effectively? And resource constraints as well. And then when you put on top of that such factors such as resistance to change from an organizational perspective and a system perspective, as well as political pressures, which then come on top of that, whether they be personal or derived from monetary factors or whatever they are, it starts to complicate the issue of taking what seems to be quite simple, really clear evidence that's done, I want to say, in the lab. Of course, it's not just in the lab, but it's, slightly removed. So yes, I'd agree with that.
Thank you. And of course, there's that famous notion about how long it takes for new research findings to make their way from universities or research laboratories into routine practice. Although interesting, I think some of the figures quoted there that in terms of that time lag are perhaps not that evidence-based. There was a very interesting paper from our colleagues at RAN Europe a few years ago that challenged the question of whether it's 9 years or 12 years from bench to bedside, and actually found that where those figures come from is very, very difficult to source. Stella, can I turn to you now? You made a really interesting comment in the chat yesterday about, I think, the need for better communication, but also better training and perhaps evidence explainers and things like that for evidence users in senior decision-making positions. So this kind of speaks to some of the central questions of this session, and particularly those that were raised in the research that Sonja described. Is this more a matter of improving research literacy among the end users of research, or is it more about getting researchers to communicate in a better way? Or is that just another false dichotomy that I've just come up with?
No, it's reasonable depending on the task of the decision makers involved. But unsurprisingly, I strongly believe that patients and the public are not an optional overhead when you're considering service delivery and which services need to be commissioned. We're part of the solution. Everybody talks about involving us in co-production and co-design, but there's very little effort at times put into making sure that patients and the public can participate, because the evidence isn't explained well. Effectively, what everybody could use, and this includes board members, would be a Ross Atkins level of explainer for the background to a topic and to set the context in which what do we need to know and what do we need to know to make a decision. And there's been so much work done on effectively our functional literacy in the UK. Everybody says, we've got the average adult literacy level of a 12-year-old, and we have the numeracy level of a 9-year-old. Well, when we look at public-facing information and the evidence that's supposed to make us involved, would you ever know that from the summaries we receive? Absolutely not. And I know there's been some fascinating work done by a range of organisations, such as Plain Numbers, that have mostly studied the finance industry and people's understanding of finance products. And they've discovered that even if 6 out of 10 people think they understood something, if they are answering comprehension questions about it, it's 4 in 10. So there's a tremendous need to make things more straightforward and for researchers to explain themselves in the public, but also some intermediaries along the lines of Ross Atkins.
Thanks, Stella. And I think we'll come back to that question of intermediaries in a little while. Now, looking at the questions from the audience, there's been a huge amount of interest in all of the talks and lots of very specific questions for Jean-Frederic, which we can't unfortunately put to him, although perhaps we'll try to collate those and get them over to him. So lots of interest in the role of the critical intelligence units during COVID-19 and how it used that evidence and collated it and the quality of evidence it relied on and so on. There's a question also for Sonja, but which I think we can discuss in her absence as well. And I'd love your views on this in particular, Stella. I think it picks up on some of the points you've just been making. So I have a question from a former colleague in this institute, Francesca Dakin. Hi, Francesca. Asking about whether we should consider engagement with decision makers in the same way as we consider patient and public involvement and engagement in study design when doing health services research. And Francesca says it's critical to build board level thinking and engagement in research design to ensure that the so what's, the practical impact actually gets out there. I've got some thoughts on that, and I'm sure you have as well, Stella.
Francesca, I couldn't agree more. I think Roger Wilson's paper on patients should be involved in the outset in creating plain language English summaries of research papers is quite well known. But as a writer and a journalist, he argued that that should be done even before you commence the study, because it starts framing how you explain the evidence and the output of the study to decision makers at the end and to the public. And I find that's remarkably helpful advice, because all too often there starts to be a strong disconnect with how the evidence should be explained to people at the end. And if you start with the end in mind, and realize that you're going to have to communicate with decision makers and policy makers, then if you're communicating to the public, you can communicate to a board.
Yeah, thank you. And the committee for the Healthcare Improvement Studies Institute that you chair, of course, Stella, is absolutely central to its design, is that it involves, it conceptualizes involvement and engagement as covering not just patients and the public, but also all sorts of other stakeholders. And certainly I would agree that communicating to all those audiences is crucial. And of course, not just communicating, and especially not just communicating at the end of a study, engaging, co-producing, collaborating, all of those kinds of things, thinking about this prospectively right from the start of research is going to be vital to making sure that it has resonance, significance and relevance for end users. And so they pick it up in practice.
Graham, can I talk for a moment about an initiative in health technology appraisal, where for 20 years, the Health Technology Appraisal International has designed a template for plain language summaries that was introduced in the Scottish Medicines Consortium, and then it's now spread more widely to other agencies. And in that, companies putting their products forward for consideration by NICE have to include what they call a summary of information for patients. And it's supposed to be written in plain language with appropriate diagrammatic aids to understanding what is otherwise a tremendously complex, very voluminous appraisal. And it is so useful because nobody in a technical appraisal can be a subject matter expert in everything that's involved, because sometimes it's awfully complex, DPhil level and beyond biochemistry, and a new model of statistics, and somebody else introducing health economics. So if you're not an expert in that, but you are an expert in health economics, you need the background and the clinical information to give you an overview to understand the context.
Indeed, and as a researcher, I can confirm that there aren't many polymaths around. There's one or two, but not many people would be conversant with all of those quite diverse forms of scientific knowledge. We have another question here, which I think was probably originally oriented towards Jean-Fred, but which I think others will have thoughts on as well. And I'd like to put it to Asutosh first of all. So Shauna Ting asks how you build trust with decision makers. And I suppose to give a little bit more context though, I'd love to frame that in terms of your perspective, Asutosh, on how, well, whether that trust is there to start with, whether that's the default position, or whether there is skepticism about all sorts of research, be that pharmaceutical or health services research. Is it seen as something that's valuable? Is it seen as something that's valid? Is it seen that it's something that's free of vested interests, that's impartial? So where are we starting from, and how can we build trusting relationships that can secure good research translation?
This is a fascinating series of discussions, and Stella's made a few points there that I before I just come into that question, Graham, if I may, I'd just like to pick up on a couple of points that Stella raised, which I think are really interesting and important. So patients first is such an overused term, but under-implemented. And everyone talks about, and genuine strides have been made in this. You know, people genuinely are trying to do that. When we look at where we were 10, 15 years ago, there is a massive difference. And even the regulators are seeing this. You know, they're trying to do things by involving patients earlier in the process. And if you look at the SPCs that come out and summary product, you know, they're written with patients in mind. That said, I think the challenge is multiple. And, you know, that's again, I guess, you know, why this institute is so important, because they're trying to really put patients at the center of this, you know, and it's almost like a raison d'etre, isn't it, by doing that. But the challenge here is we talk about putting patients first, but it's almost very, very difficult because people who are involved in research and cognizant with some of the technology and the biomedical science and all of that goes on behind it know that research is not black and white. And you have a lot of conflicting pieces of data very often. There's very often, or there's quite often, you don't have anything that's clear cut, which is why we then have to use statistical analysis to show that on the risk versus the benefit, this is better for patients. At the other end of the spectrum, and researchers come of it from a point of pure science. They're trying to investigate something, to try and prove something, to try and improve something, to try and make something go forward. And it's right, they do that without kind of involving the patient at a particular point. The question is, when do we involve the patient? Because at the other end of the spectrum, it's almost too late, because the patient needs that information. Then the people who translate that scientific data and information into what the patient gets quite often is social media and the tabloids. And by the time Joe Public gets that information, in one day, they will read 10 articles, all of which say something different, and they don't know what to do. So I think one of the challenges is, how do you have trusted, and now I'm going to bring in the trust aspect of it, how do you bring in trusted sources of information that people can go to, especially now with social media and fake technologies and all of that, that people can go to get, you know, a source of truth that they can understand and is said in simpler language. And I think that trust question, I would almost ask the question back to the person who asked it, which is, where are you trying to build trust? Because if you're trying to build trust within research teams, it's there. Trust within boards and the people who work are there. Where the trust may not be there as much is policymakers and people who are one step removed. And that is really important to do as soon as possible.
So funnily enough there, Asutosh, you've almost anticipated another great question that we've had from the audience, which is around getting the public engaged in things that really matter to them, but don't necessarily interest them. And by the time they hear about them, it might be too late. That's from Jane O'Hara. That would be opening up a whole new separate conversation that sadly we do not have time for. I will just take the liberty of asking one more very quick question of Stella. So this comes from our very own resident polymath, Mary Dixon Woods. Stella, do you have any ideas on who the intermediaries might be in terms of translating this evidence into practice? Because Ros Atkins isn't always available. Who might be well qualified to take on the role?
Liz O'Riordan yesterday said she thought the NHS England and other bodies ought to make greater use of influencers on social media. So the knowledge intermediaries are effectively the people who communicate the message to influencers who can present it in their own style to their particular audiences and those whom they influence. And yes, it has to be civil servants, but to some extent, it also has to be all of us, because it's our business to produce evidence and information that everybody can understand, because we're not going to engage people in any other way if we don't.
Thank you, Stella. Wonderfully succinct as well. So you heard it here first. Next year's This Space will be on TikTok. Thank you to the panelists. Thank you to our presenters for a really stimulating session. Back over to Liz.